Chapter 31 is going to discuss chest and abdominal trauma. There we go. My mouse didn't want to work. Sorry about that. So once again, we always review with A&P, anatomy of the chest and abdomen. The chest cavity, when we're talking about the thoracic cavity, extends from collarbones to diaphragm. Very important organs in there, I would think. We've got lungs, heart, major blood vessels. The chest wall is protected. It's got 12 sets of ribs. The sternum, we have the thoracic spinal vertebrae in the back, the scapulas on the shoulders. So physiological functions of the chest, like I said, well, the heart beats, that's good. Large blood vessels enter and exit this heart. And of course, the respiratory function. Remember, heart and lungs work together. So just a review on mechanism of breathing. You guys have seen this before. The chest wall, the diaphragm, the lungs all work together. All right. When we take a breath in, the chest expands, the diaphragm contracts, pulls that really good oxygenated air in. And when we breathe out, the chest contracts, the diaphragm relaxes. Breathing in, active process, breathing out, passive process. Right. Active inhalation remembers the negative pressure coming in, positive pressure to have that breath out. The abdominal cavity has lots of stuff going on, right? That's our guts. That's the organs of the abdomen. We classify them into 4 quadrants. I know there is if you've gone to other A&P classes, some of them have a 9 quadrant. In EMS, we stick to the 4 quadrants. So remember, anatomical is not your right and left. It is the patient's facing you. So right RUQ, right upper quadrant, LUQ, left upper quadrant, RLQ, right lower quadrant, LLQ, left lower quadrant. You need to make sure that you're taking some time and memorizing where these organs are. All right, what could possibly be affected? The liver, my cornea that I've already told you, liver not left, so you know it's on the right. The spleen being the opposite. Those are very vascular organs. They hold a lot of blood. They are solid organs. Just being kind of aware of where these are. So when you're looking at your patient in trauma, you can kind of have a determination of what could possibly be affected. So there's your solids, okay? Your spleen, your liver, your pancreas, and the kidneys are solids, very vascular blood holders. Your hollow being the stomach, the gallbladder, the duodenum, large intestines, your small intestines, and the bladder. Remember, if one of those guys ruptures, it's getting into the peritoneal cavity. Things that are leaking in there should not be leaking, cause a lot of damage. So the abdominal cavity is dynamic. It's hard to diagnose injuries. Like it says, the hollow organs tolerate trauma pretty well because they're hollow. The solid organs don't do as well. So there is always a large volume of blood in the abdomen. Of course there is. They are feeding all of our organs. So be mindful of that and look at your mechanism of injury. Pathophysiology of the chest and abdomen. So anytime we have an impact there, this gentleman right here, that's a great example of a seat belt. It probably saved his life, but it can cause extensive trauma. So it can have, a disruption in our breathing process, shock, hemorrhage, internal hemorrhage, disruption of our organs functioning. And of course, anytime we've got that type of damage, they are definitely susceptible to infection when we have things leaking into the abdominal cavity that should not be leaking. So chest injuries, we talk about blunt or penetrating trauma. Blunt, remember, nothing has impacted the skin layers, but they can do some really good damage, right? Fracturing ribs, sternum, the costal, intercostal space, cartilages. Penetrating is anything with your bullets, knives, glass, anything that's penetrating the human body can damage our internal organs and impede our respiratory process. Compression, shearing injuries, severe blunt trauma causes chest to rapidly decompress. Something falls on your patient, is laying on your patient. Shearing can cause damage to the aorta and the vena cava. Those guys are pretty important. If you remember, I've already badgered you on the heart process. So the aorta taking that good blood, making it circulate through the body, the vena cava taking the blood that's already gone through the body with the toxins in it for basically recycling. If those are compromised, our blood flow is compromised, not a good thing. Chest injuries as a whole, open or closed, right? If there's a penetration or if it's a blunt force trauma. So rib fractures, they are painful, not usually life-threatening. It depends on how many are fractured, right? What, falling off a swing and cracking a rib, or football cracking a rib, versus getting T-bone in the side and having all your ribs impacted, like this particular person or this model. You got to assess that. It's going to be very painful. Most of the time with this injury, what we're looking at is the lung, the respiration, the exchange. If they don't want to take a good deep breath in, are they getting the volume of air they need to get for proper respiratory process, right? Rib fractures can lacerate vessels. They can penetrate lung tissue. So we really need to make sure we're stabilizing rib fractures. Flail chest is a fracture of 2 or more ribs in 2 or more places. When that happens, the portion of that chest wall is now unstable. Okay. These patients are not going to want to take deep breaths in. So we should be thinking about an ALS intercept for pain management so they can breathe more comfortably and they're less in a lot less pain. You need to make sure that you're stabilizing that injury. So paradoxical motion is the term we use to describe that movement of the flail segment opposite to the movement of the chest cavity. So when you see this, and I believe we should have some videos. I'm not sure where they're at, but I think I've got some in here. But so basically, when they're breathing, when you breathe, your chest expands. These patients are going to do the opposite. That's that paradoxical motion. When they breathe, it's going to suck in. So it's going to look a lot different. So there it is. There's the flailed chest. We've got 2 or more ribs broke in 2 or more places, causing that chest wall or that thoracic protection to be compromised. So there's that breath in, and the flail is going to move in the opposite direction. So what do we do for these? Consider your mechanism of injury. It's going to be painful when they try to take a breath, tenderness. You might have some bruising and redness, respiratory distress. They're guarding, they're self-splinting. They don't want you to touch it. Signs of shock, hypoxia, get some oxygen, treat for shock. Consider the need, like I said, for ALS so we can help manage their pain. Position of comfort. To treat a flailed chest, we're going to use bulky dressings, a pillow, some sort of cushion on the affected side so it starts to decrease that movement. All right. And then I'm going to show you some videos in class. I thought they were in my PowerPoints, but they must not be, of what flail chests look like. Okay, so when we do flail chest treatment in our skills day, we will go over those videos. So you'll be able to see what that looks like. Penetrations, these are difficult to tell what's injured. Like this knife right here. Okay, is it 6 inches long? Is it 4 inches long? We don't know. All right. Anytime something impales the core, especially the core of the human body, look where that's at, lungs, heart, very close to those vital organs, could definitely be a life threat. Open wounds allow air into the chest. Okay, so this one in particular, no, because the knife is still in there. If the knife was pulled out, we now have an imbalance in pressure. Remember that negative pressure going in when we're breathing, positive pressure on exhalation. So we are getting air into the chest that shouldn't be getting into the chest that way. Okay, so as that air continues to get into the chest, if we don't shut that down, we are going to get pressure in the chest cavity. It's going to continue to build because it doesn't have a way to exit, and it's going to cause our lungs to eventually collapse. And then you're really going to have to call me because I'm going to have to do some decompressions to help you out. So if there's a penetration, let's take a look at, try to get a description of the object, see if there's an exit wound. Definitely listen to your lung sounds, identifying a pneumo or hemothorax. We'll talk about that in a little bit, what that means. The biggest signs and symptoms, they are going to have a lot of difficulty breathing. If you've got a pneumothorax or hemothorax on board, you're going to have absent, unequal lung sounds. Hypoxia, you're not getting good respiratory exchange. If the lungs have to work harder, so does the heart. You know, heart and lungs work together. Signs of shock, tachycardia, fast breathing, pale, and then a late sign of shock, of course, is when they have that drop in blood pressure. So if we have, let's take that knife, and that knife was out on the last picture. We've got what's called a sucking chest wound. What I was describing. So air is drawn in through that chest, that hole. Okay. Makes kind of a sucking sound. I do have, if it's not in this PowerPoint, once again, I do have these videos. We'll watch them as to what sucking chest wounds look like. It actually makes a sucking sound. You may see some air bubbles within the wound, and the patient is gasping for air. So remember that negative pressure we like to hold, positive pressure, that's been compromised. You just poked a hole in it. All right. So we have to stop the air from getting in there. And how we stop the air from getting in there is to put what's called an occlusive dressing on it. So there's your occlusive dressing. You're going to seal 3 sides and leave one side open. It's going to create a little bit of a flutter. So that way it stops additional air from coming in, and it allows, when the patient exhales, to try to get some of that air out. Okay, so it's going to flutter. So yeah, make sure your scene is safe whenever we've got these type of injuries. Consider ALS for some management of pain and other assistance, cardiac monitoring. ABCs, seal that wound, get the occlusive dressing on immediately. Treat for shock, high flow oxygen, keep them warm, immediate transport. So the occlusive flutter valve dressings, like I said, they stop the movement of air. So to get that flutter valve as that patient, you know, when we do the 3 sides, and we're going to do that for the chest cavity, as the patient inhales, the dressing seals it, so no further air is getting in. As they exhale, that free corner, that edge, acts as a little flutter valve to release air. All right, so there it is. So a pneumothorax, we're going to talk about terms now, all right? So within the chest cavity, what does that mean when I say pneumothorax, tension pneumothorax? Hemothorax, hemopneumothorax. We're going to talk about traumatic asphyxia, cardiac tamponade, and aortic injury. So internal injuries here, but we need to look at signs and symptoms to see if these are on board. So a pneumothorax definition, when air accumulates in the chest cavity to the extent that there's no more room, basically, it can cause the lung to collapse, and that is what a pneumothorax is. A tension pneumothorax, pressure from the air in that cavity gets so great that it's putting pressure on the heart and vena cava. It's going to continue to shift. here's where you're going to see what's called that tracheal deviation, right? If that trachea is not midline, starting to shift, we've got some serious, serious patients. So there's a good drawing of this. So got a chest penetration, air's getting allowed to get in there. That air can't get out because it's not being taken in the way that we're supposed to, right? We take air in the nose and the mouth, and we exhale through the nose and the mouth. Well, this is getting taken in from an external source that has no way to get out. So the air continues to enter that thoracic, the chest wall there. And as we run out of room, basically, the lung's going to start to collapse. If we let this keep going, it's going to start affecting the other lung. And that's where we're going to start getting pressure on the heart. Remember where the heart sits, kind of right between the lungs there to the left a little. It's going to definitely impede the heart capability, and then it can eventually collapse that other lung. So we've got to shut that down. You will definitely need to be calling an ALS intercept so we can try to reinflate, kind of, I guess that's the best way to say it, that lung. So like I said, the pneumothorax, the tension pneumothorax, diminished absent lung sounds on the affected side. That is what we're going to be looking at. The jugular veins, we're talking about that jugular vein distension term. Take a look at that. Is that what's going on? The trachea shifts to the opposite side of the affected, of the injury. The hemothorax, hemopneumo, the chest cavity fills with blood, right? That's what hemo being blood, thorax, and a hemopneumo, the chest cavity is filling with blood and air. So there it is. I do have a good picture of it. So great picture of this. The pneumo, there's the chest penetration, air's coming in, causes that lung to collapse. Hemothorax, it's blood getting in there, causing the hemothorax, and then blood and air causing pressure on that lung, causing it to eventually collapse. So what we're going to do on the ALS level, so I keep saying call ALS. So what we're going to try to do is we could do a procedure called a needle decompression. We're going to basically stick a needle into their chest cavity, either in the front or in the side by the armpit. And we're going to basically try to release that air, right? And once again, got a great video that I'll let you guys watch on somebody performing this. It's actually from a movie, but it does show a really good demonstration of what happens when we use that needle and we try to, quote unquote, reinflate if we can. Traumatic asphyxia, sudden compression of the chest, forcing blood out of the organs, rupturing the blood vessels. Look at this gentleman from the chest up. He's definitely got asphyxia going on. The neck and the face are much darker than the rest of the body, can cause bulging eyes. Think of all the pressure. Injuries like this, something's usually fallen on your patient, or they're, you know, I don't know, they're trapped under a car or whatever. Hangings, you'll see this, neck and face up, distorted color. Tamponade, it's a direct injury to that heart, causing blood to flow into the pericardium. The pericardium sac is around the heart. It protects the heart. It rarely leaks. So if we've got an injury causing blood to go in there, it's going to put so much pressure in that sac that the heart chambers can't fill, and they're going to go into arrest. So there it is, our telltale sign. There's your JVD, jugular vein distension. Shouldn't be sticking out like that. Patient is going to exhibit shock signs. The blood will start backing up into the veins because it has nowhere to go. Narrowed pulse pressures just means you're going to watch your blood pressure, and the difference between the top and the bottom is going to start getting closer together. So not a good day for this patient. He needs a surgeon. The aorta is the largest artery in the body. We know that any penetration or impact on that aorta can cause severe damage. Blunt trauma, force of injury, mechanism of injury can sever or tear the aorta. So if you've ever heard of a term of somebody having a ruptured aorta, that's exactly what happens. Most of the time it is fatal because of the amount of blood and the force of the blood that's coming from the heart. dissection, the layers start tearing, the blood flows between the layers, and as that dissection worsens, once again, it's fatal. Okay, what are we going to do about it? You're going to protect your ABCs, get an ALS intercept so we can do cardiac monitoring, and these guys need a surgeon immediately. Their chances of making it are slim, but that doesn't mean we're just going to leave our patient, right? We're still going to give it the college try, get him in there, see if we can get them to the hospital and get some definitive care. An aneurysm, we already discussed this in medical. All right, so we got a rupture going on. Once again, it's most often fatal. So how do we know if it's an aortic injury? Well, we don't, because we're not, we're not perfect, right? We don't have scans. We don't have CAT scans, MRIs, but anytime, look at your injury, pain in the chest, abdomen, or back, signs of shock, differences in pulse or the blood pressure between the right and left arm. Okay, so are we seeing one pulse stronger than the other? Are there numerical differences? Is the blood pressure different? Check your extremities out. Note that. Let the ED know your findings. Commotio cordis or commotio cordis. I've heard that said twice, two different ways. It's uncommon, but it does happen. Think about your baseball players. They take a line drive right to the heart. It's like the money shot. I shouldn't say that, but it's so rare that something penetrates that chest when the heart is vulnerable, hits it, stops the heart immediately. Okay, so commotio cordis, it's just an interruption. All right, it's an interruption of the heart function. So if untreated, it's going to go into VFib, ventricular fibrillation. Yes, if you come into commotio cordis, the heart's been impacted, you should be ready for cardiac arrest. Treat them like a ventricular fibrillation patient. You know that is a shockable rhythm. Start your CPR, keep things going, manage your airway, be ready to defibrillate immediately. So for pneumothorax, what are we going to do about it? Well, they're going to be breathing. They're going to have some hard time breathing. Uneven chest wall movement we're going to look for. Absence or reduction of breath sounds on the affected side. Tension pneumo, same thing. We're going to start looking for JVD, tracheal deviation. Hemothorax, are they coughing up frothy red blood? Right, that means we've got blood into the lung cavity of the lungs. Remember, they don't like blood in there other than through the vasculature. So if they're coughing up frothy red blood. Traumatic asphyxia, let's look for, once again, distended neck veins, JVD. Head, neck, and shoulders are dark blue, purple, bloodshot, bulging eyes, swollen blue tongue, lips, chest deformity. We've probably got a asphyxia there going on. Tamponade, once again, JVD is our big telltale sign for these chest injuries here. Weak pulse, low blood pressure. The pulse pressure is starting to decrease. Our heart's having a real hard time pumping. Aortic dissection injuries, tearing, ripping, pain, radiating into the back, differences in pulse or blood pressures between right or left, palpable pulsating mass anywhere. Do not touch that. If you see that, note it, let the hospital know immediately, and then be ready for cardiac arrest. So what are you going to do? Call me. Call ALS for these pneumos tensions. Seal all your open chest wounds. Okay. Allow air to be expelled out for your tension pneumos. Manage ABCs. Keep the patient comfortable. Maintain your airway. Care for shock. And once again, you're going to probably need us to come and do a decompression to get that lung reinflated. So abdominal injuries, they can be open or closed. Again, we discussed that kind of already in the last chapter. Internal bleeding can be severe, of course, if organs or vessels are damaged or ruptured. An evisceration may occur. An evisceration is organs coming out, protruding through the wound. So somebody stabs somebody in the gut and you're seeing intestines. What are we going to do about it? All right, that's what we're going to talk about. So there's your evisceration. not a pleasant injury. Going to be a visual distractor for sure, right? Still manage your ABCs. Looks like this patient got stabbed, and then the peritoneal cavity was impacted and it came through to the outside. So your solid organs, life-threatening blood loss, injury to the diaphragm can cause detachment. So how are you going to know? You're probably not. You're going to look for bruising. You're going to look for distension. So that means the stomach's hard, pain, rigidity, breathing difficulty, throwing up, weakness, thirst, your lacerations, punctures, pelvis, middle, lower back. Patient, when they have abdominal injuries, they tend to be very painful and they don't want to move and they're guarding. All right. So do the best physical assessment you can without causing severe discomfort to your patient. So the path of the bullet, gunshot wound, there it is. We have no idea where that bullet exited. We're going to try to do a great physical assessment and find that. That he has a chest tube already in. We don't do that in the field anymore in EMS. Medics don't either, just critical care may, but that's out of our scope of practice. We're going to definitely put an occlusive dressing on that sucker. It looks like there's one already on there. They just did the chest tube through it to drain that blood out of there. So remember, bullets do not take a straight path. So we got to keep that in mind. Watch for vomiting, big one on abdominal injuries. Maintain your ABCs. They may want to be on their back if there's no spinal compromise. If their legs are flexed, like your legs are tucked in, sometimes that will reduce tension on those abdominal muscles, help with pain. ABCs treat for shock. Do not give patient anything by mouth. We usually don't anyway. You guys know that already. I've already told you that. And watch your vital signs. Consider your ALS intercept. External bleedings, to address that. Eviscerations or anything that's open in the abdominal cavity. Sterile dressing, irrigate it. Okay. Get that on there. Moist sterile dressing, because that organ likes to be in a moist environment, right? So get that dressing on, moistened with saline, and then you're going to do an occlusive dressing with all 4 sides sealed. The abdomen doesn't need one side open. It doesn't breathe. Okay. All 4 sides sealed. All right. So you got a patient here shot in the chest with a nail gun. Ouch. You applied a occlusive dressing. He is deteriorating quickly. He's having extreme difficulty breathing. His color looks terrible. He's got cyanosis, that blue grayish of the skin. And the breath sounds have become almost absent on the side with the impaled nail. What complication is this, and how can you correct it or manage it? Okay, so I'm going to leave you with that. Your critical thinking question of the day. And that will take care of chapter 31.